Hello, welcome to our neurofibromatosis symposium. I'm Dr. Khatib from Hematology Oncology, and I'll be talking to you today about the treatment of plexiform neurofibroma with selumetinib. So, plexiform neurofibromas are complex benign tumors that arise from the peripheral nerves in patients with neurofibromatosis. They can cause significant morbidity due to their size and location, necessitating effective management strategies. So now we're trying to classify those plexiform neurofibromas based on their shape or type and how they evolve with time. So this slide tries to show you that on the left, we have a type that progressive, that increases in size progressively, and another type that doesn't progress and stays the same size. Also, we're trying to separate those plexiform neurofibromas into three types. One is called nodular, which is usually under the skin or along the length of a nerve, or diffuse, which is less defined and it's not specifically localized to one spot. And then the third type is invasive, which can invade the tissues and pushes them around, as you see in this third picture. Now, those plexiform neurofibromas can cause morbidities or issues, problems for the patients with neurofibromatosis. Here are some of the problems that we encounter. For example, pain is one of the common findings. Problems with the intestines, bowel dysfunction, like vomiting or constipation if it pushes on the intestines. Motor dysfunction, such as weakness of an arm or a leg. Visual problems, if it's close to our eyes or optic nerves. Airway dysfunction, if it's close to your trachea or windpipe. Bladder problems, if it's close to the pelvis. Or disfigurement, cosmetic issues, which is a common problem with plexiform neurofibromas and neurofibromatosis. So Dr. McKinnon spoke to you about the surgical management for these plexiform neurofibromas, and sometimes surgery can be successful, but sometimes the location does not allow us the ease to do a surgery. And there could be risks in certain areas when the neurofibroma is close to vital structures or vital nerves. So in those cases, the management, in addition to surgery, would require us to add something else, such as the MEK inhibitor. And this could be either for the cosmetic reasons, or we're concerned that those neurofibromas are changing from benign to malignant, or if the pain is persistent and not getting better. So one point about those plexiform neurofibromas is that they tend to grow rapidly in the younger child. If you look at this graph that shows you the age from 10, 20 to 50 years, you can see that most of the growth, these blue dots, occurs in the first 5 years to 10 years. And then after the age of 10 or 20, there doesn't seem to be a lot of growth in these plexiform neurofibromas. The other point is that once somebody develops a plexiform neurofibroma, it is unlikely to resolve or shrink by itself. And this curve shows you that among a group here of 41 patients with neurofibromatosis, a big percentage had problems with pain, requiring surgery, or problems with motor weakness. Those were the most common issues faced by the patients with plexiform neurofibroma. So again, the types now are classified into superficial, nodular, or circumscribed, and they could be deep or diffuse or interdigitating, which means like fingers going into the tissues. And we're going to show some MRI examples of some of these types of neurofibromas. On the top, you can see the neurofibroma of the orbit around the left eye here, and that the MRI shows us how it involves all the tissues around the eye and in the face. In the second area, the MRI tells me how deep this goes in. This is the top part of the chest, and you can see that the neurofibroma goes well into the lungs in the top of the chest. And then the MRI also shows me how the neurofibroma relates to vital structures here, looking at the muscles and the nerves around the area of the leg. These are some other examples of MRIs showing us those plexiform neurofibromas that look nodular. You can see here they're round and they look that it's possible to be removed completely. However, we have to be careful that these nodular neurofibromas may be close to the nerves, like in this case, the sciatic nerve, or in the second case, the brachial plexus around the arm. And we have to be careful not to damage any of these nerves when we remove those. Now, this is an example of a patient who has a plexiform neurofibroma in this location. You can see the whitish color. And this patient was being treated with a MEK inhibitor, selumetinib or cosilugo. But you can see here that this type of MRI, called volumetric MRI, can give me an accurate measurement of the volume or size. And if you can see, moving from the left to the right, that even though overall it seems to occupy the same size, but if you look at the measurement, it's more skinny or thin, showing that the volume is improving with the treatment. So this is a nice way to look at MRIs, called volumetric measurement. And these also are other types of what we call the target plexiform neurofibroma, which, if you look at the neurofibroma, you can see a black dot in the middle, and this is typical of a plexiform neurofibroma that's benign. And when we see that, we don't worry that it's anything bad or malignant. So this is where selumetinib works. As Dr. Bauer and the teams have mentioned to you, that neurofibromatosis is due to a mutation in the NF1 gene that leads to the activation of this pathway. So this is a pathway that makes our cells divide and multiply. And selumetinib is an inhibitor of this pathway. It's called the MEK inhibitor, and it stops these cells from multiplying and growing. So children with neurofibromatosis should be followed by a geneticist, and they should be coming for regular follow-up and to look at all the problems that may arise due to neurofibromatosis, or to make sure that they have no problems. So if a patient has neurofibromatosis and there's an interest in using the MEK inhibitor selumetinib or cosilugo, they are referred to the hematologist, oncologist to have a discussion and to evaluate whether this treatment may be useful or not. It's very important to know what the risks, side effects, and the benefits are, and to define the goals of treatment. What are we looking to achieve once we start the treatment? And then we have to obtain a baseline evaluation before we start the treatment. So the baseline evaluation includes a physical exam. It includes usually an MRI to see what we're dealing with. We have to do certain blood work, looking at the blood counts, chemistry test, a blood test for muscle enzymes called CPK, and then we need an ophthalmology evaluation before starting the treatment, and then echocardiogram for the heart also before starting the treatment. These are for a baseline, just in case there's any side effects. Now, sometimes we do a total body MRI so we can see if there's any other plexiform neurofibromas inside the body that we cannot see on physical exam, especially in the abdomen or the chest. These are just examples of some plexiform neurofibromas here in the leg, and here we see another one in the left groin area. So this is a test that's useful to look at the total body and how many or how big the neurofibromas are. Once we start the treatment, it's important to monitor the patients on a regular basis. And that's to see if the treatment is working, but also to look for any side effects and take care of these side effects. So we need to do a physical exam, a blood work, and the echo of the heart every 3 to 6 months, and the ophthalmology evaluation every 6 months. It's important to know that usually the ophthalmologist, eye doctor, sees patients once a year, but if you're on the medication, that should be every 6 months to make sure there's no side effects. And the side effects could include skin rashes, gastrointestinal issues, fatigue, visual problems. So we're going to go a little bit into more detail into what are these side effects of the selumetinib or the MEK inhibitor. The most common side effect is a skin rash, which may look like this, eczema. We can prevent that with moisturizing the skin at least twice a day, using sunscreen because the medication makes our skin sensitive to the sun. And then we have a regimen of creams, including steroid creams, from the mild steroids to the stronger cortisone creams like triamcinolone. The other skin rash that we see more in teenagers is acne. This could be on the face or on the back or chest. And this can be prevented with certain antibiotics like clindamycin, doxycycline, clindamycin lotion, as well as the cortisone and steroid creams. Those are also useful in preventing the acne rash. Sometimes the scalp on the head can be very flaky and dry and itchy, and the ketoconazole shampoo once or twice a week can prevent that or treat it also. Another skin finding is paronychia, or infection around the fingernails. And the way to prevent that is to not to cut the nails too short close to the skin, and sometimes soaking the fingers in an antiseptic solution, sometimes local antibiotics, or even the cortisone creams or other antibiotics may be needed if this happens frequently. Other than the skin, some kids or young teenagers may get nausea and vomiting. So it's important to have those nausea medications at home. Sometimes eating small and frequent meals, avoiding spicy or greasy food may be helpful. And then fatigue may be common in some of those patients. Other side effects may include diarrhea. Those are not common, but it's important to be alert and aware that it's important to stay hydrated. And if the diarrhea happens, we could use over-the-counter medications such as Imodium or loperamide. Uh, we also have to measure blood pressure during the treatment, make sure that's not elevated. Some uh, patients may have muscle pain, and we monitor that with some of the blood work we do, the CPK or creatine kinase. But as long as the patient is not limited with exercise or having significant pain, we don't need to stop the medication for that. The visual changes are important, and this could be blurring of the vision or problems with the retina. Fortunately, we haven't seen it in any of our patients, but because of that, it's important to have the regular eye checkups every 6 months. The liver toxicity, also not common, but this will be apparent in the blood work that we do every 1 to 3 months. It's important when someone is taking Koselugo to make sure that they're not taking other medications that can interact with the Koselugo, such as fluconazole, which is used for fungal infections. It's also important not to get pregnant or be breastfeeding. So the studies for selumetinib and plexiform neurofibroma have shown that at least 50 to 66% of the patient may have a reduction or shrinkage in their plexiform neurofibroma. So that's an encouraging number. We're excited about that. And this is a diagram that shows you all these patients. Each one of these bars is a patient, and you can see that almost every patient has shrinkage from 0 to 20%, all the way up to 50% shrinkage of the tumor. So all these, this is called a waterfall diagram because it's like a waterfall, and it shows you how the majority of the patient has shrinkage with time. And the next slide shows you how we give the selumetinib. It's given based on the height and weight, body surface area, twice a day. It's important not to chew the tablet. It has to be swallowed. And the good news is that it can be taken on an empty stomach or with food. So we just changed the indication that it's okay to take the Koselugo selumetinib with food, and that doesn't affect the way it works. And if you look at a group of patients who were taking the medication, usually here for 2 years, you can see that the shrinkage in the size of the tumor happened in the beginning, but in some cases it happened later on, after a year of using it. And this shows it in another way for the patients who were taking the medication. 82% had the response continue for more than a year. So the shrinkage happened sometimes in the second year after taking the medicine for more than a year. So the question is, for how long do we take this medicine? The studies that were done suggested an average of 2 years of taking the selumetinib. But each case is different. If we see that there's improvement, we could continue more than 2 years. There are patients who've had it for 4 years. There's cases now up to 7 years. So it depends on the patient, but usually a minimum of 2 years to start with. And the other question is, how long do we have to take the medicine before we see the shrinkage? So in general, the 40% saw a response with the first 4 cycles or 4 months. After 8 months, 73% had a response. After 1 year, 97%. So, but there's a certain percentage where you have to do the full 24 months before you see a response. But on average, we see an improvement after 7 months. And it's important to know that if any of the side effects are significant, what we call grade 3 or 4 side effects, then we have to stop the medication and go back at a lower dose. So we can reduce the dose, and sometimes it does work at the lower dose. So it's important to have those regular follow-ups. Usually we see a patient on the treatment every month in the beginning, and then every 2 to 3 months once they're on a good dose and without any side effects. And the reason we want to see the patient is that it's important to monitor the size of these neurofibromas and sometimes do scans every 6 months or once a year to make sure that those benign tumors don't change into malignant tumors, which is not common. 90% of the cases, this never happens, but it's sometimes it does, and it's important to keep an eye, make sure there's no sudden growth in the size of the neurofibroma or sudden worsening of the pain. This is an example of a neurofibroma that grew fast and changed from a benign to a malignant. In those cases, we may do a PET scan that can tell us if there is any abnormal activity. But fortunately, this is not common, but it's important to know about it. So to summarize, selumetinib, the conclusions are that the management of plexiform neurofibroma requires a multidisciplinary team that involves the oncologist, the neurologist, the surgeons, geneticists, radiologists. So it's a multidisciplinary team, which we have here at Nicholas Children's Hospital. The second conclusion, that we need to learn more about the use of this drug selumetinib over the long term. What happens after 2, 3, 4, 5, 10 years? So far, it hasn't had any bad side effects, but it's something we're looking at, and we're collecting more information as we move forward. We're still exploring combinations of treatment. How do we combine the selumetinib with some other drugs, such as the ones Dr. Fernandez spoke about earlier? Could it be better if we combine this medicine with other medicines, combine it with surgery or other procedures? But in conclusion, we think that selumetinib is a very promising advancement in the management of plexiform neurofibromas, and that children and maybe young adults would benefit from using it when it's needed. Thank you for your attention, and hopefully Dr. Bauer can answer your questions.